white, associated mostly with tuberculosis, and you have also family history of lung cancers. Now, after visualizing the malignancy, you need to know that you have a patient that it can deviate also. Let's say the lesion here, but it's deviating like that. It's deviating away from the affected side. Let's say the lesion is here, but it's deviating this other way. It means that it's deviating away from the affected side. If it's deviating away from the affected side, it means that there is a pressure on this side here. There's a pressure on this side which is pushing the lungs and also pushing the trachea and the mediastinum away from that side. So you have to think of those things. Those things can be a pleural effusion. So a pleural effusion, which is particularly massive, may push the lungs and push the mediastinum to the other side so that it moves away from the affected side. The trachea moves away from the affected side. You have the other pathology after trachea moving. So after pleural effusion, you need to know that you can also have after pleural effusion, you can have also a case of a pneumothorax. Pneumothorax, particularly a tension type pneumothorax where there is high pressure that is produced, is it correct? Because you have a tension type pneumothorax which can be produced at the level of the chest. Is it correct? When you have a tension type pneumothorax, it is capable of compressing that lungs and pushing the mediastinum to the other side. Is it clear? So those are etiologies which can, or we have also other elements which can cause fluids in the level of the pleural fluid. We have a hemothorax when there is air. We have chylothorax where there is chi is just fluids of the thoracic duct or the lymphatic circulation entering into the pleural space. You have pneumothorax, you have chylothorax, you have pneumothorax, you have chylothorax, you have pneumothorax, you have hemothorax. Hemothorax is when there is blood, basically. So those are the different elements that you have to understand. So now the next element after that, after the airways that you have to speak about, you need to speak about the breathing. Basically, I've also forgotten another element that is very important in the airway. In the airway, you need to visualize the bronchi. Basically, you need to visualize the bronchi. And when you visualize the bronchi, there's a particular sign that is going to be shown, but I'm going to discuss it more when you're going to visualize the part of the breathing. Basically, and that one is called the air bronchogram. Air bronchogram is when you see a darkish, when you see a low line of lucency within an opacity. Basically, it's an air bronchogram. Basically, so when you visualize it like that, you can know that it's air bronchogram. Now, the next thing is that you can see also peribronchial adenopathy, peribronchial opacities. Basically, so if you see lines here like that, basically, what you need to know that there can be opacity just close to the bronchi, so to the bronchioles. Basically, it can be opacities which are close to the bronchioles. Opacities which are close to the bronchioles are called peribronchial opacities, and peribronchial opacity can pertain to two things. Basically, it can either be a peribronchial artery. It can either be a peribronchial artery, or it can be a peribronchial lymph node. Peribronchial lymph node. Basically, now the peribronchial arteries are usually small. Basically, when you see peribronchial arch, it means that you see lines. Basically, you see opacities like lines. You think more of peribronchial arteries. But when you see opacities which are nodular like this, you think of peribronchial lymph nodes. Basically, when you see lines, you think of peribronchial artery. When you see a nodular aspect, you think of peribronchial lymph nodes. Basically, so when you see these lines that are very large, they are peribronchial artery which are hypertrophied, particularly in the case of a pulmonary hypertension. So those are pulmonary arterial hypertrophy. Basically, so when you visualize it, now when you see large peribronchial lymph node, we are not even supposed to see the peribronchial lymph node. Those are peribronchial lymphadenopathies. When you visualize peribronchial lymphadenopathies, it means that there may be an infection, a chronic infection, or there may be a malignancy Is it clear? Or even an autoimmune disease. So those are the different things that you have to understand. Particularly this peribronchial lymphadenopathy, when they are diffuse micronodular reticular opacities, they are showing miliary tuberculosis. Is it clear? So those are the different things. The next point also, at the level of the hilum, that's the entrance of the lungs. Is it clear? You can visualize opacities at the level of the hilum or the entrance of the lungs. Is it clear? It's called the hilum. The hilum or the entrance of the lungs. At the hilum, if there are opacities here, generally you need to know that what the hilum on the right side is going to be commercial. Is it clear? It's going to be commercial, while the hilum on the left side is going to be like a wing shape. Is it clear? So if you see an opacity which is like this commercial, it is more of a hilar opacity, a right hilar opacity. And if you see an opacity which is more like a wing shape on the left side, it's more also of a hilar left opacity. Is it clear? A hilar lymphadenopathy. Those are typical to show you that the hilum, they are affected. Is it clear? So the lymph nodes, they are affected, and they can be affected in the case of infection or in the case of malignancy. And the malignancy can either be primary malignancy or secondary malignancies of the lungs. So those are the different things that you need to visualize when you have the airway problems. Now we are going to continue with breathing disorders.